Zone 3 podcast. We're back in the studio. We were on the road for a bit.
We were.
My name is Robert.
Yes, this is Reggie.
This is Reggie. And today we're joined by Dr. Baxter. Dr. Baxter, thanks for joining us.
Thank you. It's good to be here.
Thank you. You are a neuroscientist, if I have that correct, and you're here to discuss functional MRI. So thank you.
Right. Specifically, I'm a clinical neuropsychologist.
Oh, okay.
So, it includes neuroscience. If you want the real breakdown of my degree, I'm a clinical psychologist with a specialty in neuropsychology and then another specialty in neuroimaging. So
does that mean you're an overachiever?
That means she has proud parents. That's right.
Who don't understand what I do.
Well, obviously, we're very lucky to be joined by you. Thank you.
Thank you.
If you would, tell us a little about yourself other than professionally. Like, what do you like to do for fun? You were mentioning mountain biking.
Oh, yeah. I just came back from mountain biking. So, tried to freshen up before I got here. But we did sort of a short version. But, yeah, we've been picking up mountain biking during the pandemic. So
nice.
We just like to replace it with something nice and dangerous for the.
So it's better than picking up drinking, maybe.
Exactly. Well, no comment on that, but definitely we're.
Where are you originally from?
I'm from Michigan.
Okay.
So I went to the University of Michigan for my undergrad, and then I worked in a bunch of different labs and did a lot of different things, and then decided to go back to graduate school after kind of living across the country. Moved to San Francisco, Chicago, then went back to grad school at this specialty program in the Chicago Medical School in clinical psychology, and figured out that neuropsychology and working on the brain was the coolest thing ever.
Isn't it?
Yeah, so I got on that. And then after that, just to continue on, I went and did an internship, a clinical internship at Long Island Jewish Medical Center in New York City, and then went and did a postdoc at Dartmouth up in
nice.
New Hampshire, Vermont area, and then started at positions in Phoenix. So I've been in Phoenix about 20 years.
What was your favorite location?
Oh, I do a lot of mentorship of postdocs in neuropsychology and graduate students, and I picked up this whole philosophy of you have 3 degrees of freedom. There's location, there's the job, and there's money, and you're never going to get through all three. Or you shouldn't really strive for all 3 at once, right? So I've moved around the country so much, I realized that it just depends. There's great parts of all of them. So I don't know. I'm very content here. It's surprising because I never realized that I would like Phoenix because it wasn't really on my radar.
Right.
But it's turned out to be great. And plus, I can leave my house and go mountain biking for a long time, which is fabulous, and then so I don't have to go anywhere to do fun things,
Nice.
That sounds fun. You're more active than I am. So at the risk of dividing the room, are you Michigan or Michigan State?
Oh, Michigan is my school, so go blue. I tend to. I have a funny story. There is somebody I know that is in our community actually who went to University of Michigan, and we are so diehard. Had a tooth problem, went to a dentist who found out he was from Michigan, and the person said, I will put the crown on for free if I can put a little M on your tooth. And so they got a free crown because he now has a little Michigan M on his tooth. And when people say U of M and they're from Minnesota, I'm like, no, you're not allowed to say that. So,
Taken.
So Michigan. It's the bottom line.
I understand. I've got some friends, and they are diehard Michigan State.
Well,
they bleed green.
Family members, are from Michigan State, but I don't even deign to go there because everybody knows we're better, right?
Well, the joke I make, I've never met anybody from Michigan I don't like, and so far that's been true. I've been told by people from Michigan that they exist, but I haven't met them. But anyway, so we invited you here because we work with you. We do a lot of functional MRIs at our current facility, and that's where we kind of cross paths. I know as far as the reality of TV and what it portrays, with you see how House like
Oh yeah. House.
scans patients, and
Right,
that's,
my
doctors
nemesis.
don't scan patients, but Dr. Baxter scans patients.
Yeah.
I've seen you
Right.
scan patients.
Right.
You actually do the MRI yourself.
Well, I was grandfathered in because I've been around for so long that back when I first started it, there are some centers even now that, depending on your research, if you're a engineer and you're doing research, those folks oftentimes can scan.
Mm-hmm.
So I learned scanning years and years ago. So because I learned it, I kind of got grandfathered in to be able to scan. And so I certainly am not at the technical level of an MRI technologist, but for what I need to do, and certainly like the safety issues and things like that, I
Right.
can scan.
Nice.
I know not to touch the quench button, so things like
and
that.
I've seen you scan, and you know what you're doing.
Right.
Yeah.
Yeah, I was
Yeah.
impressed. Well, thank you again for joining us. We're going to kind of let you steer the conversation. There's so many things to cover. I know we want to definitely cover DTIs, tractography,
Okay.
Right.
brain mapping, that sort of stuff.
I know
It's
one
all
of
in-
my biggest questions is like, how far has it come? Like, what is considered clinical functional
Oh, yeah.
studies versus, research?
Okay. Well, so functional MRI for a long time was solely research, or
Right.
almost solely research. Like, I frankly don't know who kind of started transitioning into the clinical realm. I think it might have been, people like Susan Buchheimer, who's at UCLA, and I know her really well. And she's, she was doing it back in the day. They were really, but for the most part, it started as a research. And in the
Right.
olden days, when scanners weren't really good, we were just so happy to get visual field activation. And now, it's pretty, easy to map the visual field easily. And then if you want to get into more depth, you can go really dive deep into that. So it started out as a really nice tool for research, and it continues to be a nice tool for research. And I personally do research. So I change my hat on and off depending on what I'm doing. And I actually scan differently depending on what I'm doing, because, and I can get into some detail with that.
Sure.
But the thing about the fact that it's basically in research and then we use it clinically has caused me no end of problems in some ways, because patients and also some physicians get it kind of confused, right?
Mm-hmm.
So if I could sort of take a minute to talk about the difference in some broad strokes and what I need to tell people, it will kind of help. And I do probably have a slide in here, but I'll just kind of jump in there.
Please do.
So, so in terms of research, it's very, very helpful to look at groups of people who have some sort of disorder, or even just a group of controls that you put under different experiments, and decide, okay, is there a difference between the two groups? Okay, so let's take an example that kind of I come across a bunch. So say you have a bunch of people with ADD, or attention deficit disorder. If you did a
Robert.
group, probably 3/4
Sure.
of us in the room, right?
Right.
But if you did a research study and took a group of people with some defined characteristics of ADD, and then another group, and you said, okay, I want to look at attention in those two groups, and you use a really commonly used functional MRI task called the NBAC, which is just like you have to kind of see a number, or you see a letter, and then when the letter's repeated, you press a button, or if there's a break of one, in between, you press the button, then that, it's a working memory task. You compare those two groups, you're going to get big differences, because people with ADD have some weaknesses in brain function that's going to look different in the two groups. And so I do research in not that particular disorder, but other disorders, or brain differences, let's say,
Right.
and I find differences between groups. Well, in any particular person, you can't scan that person with that task and say, oh, I know you have ADD, because that's not the nature of functional MRI, and I'll show you why that's not the nature. So I oftentimes, it used to be, it's a little less now because I've been in the general area, long enough that I think I've talked to enough physicians who would be likely wanting to refer people to me for these diagnostic tests, but they don't do it anymore. But what you do for, you can't really tell anything diagnostically from functional MRI at this point in time, in my opinion. There's one person who does that for specific types of disorders, who have created like such a battery of tests that people go through under functional MRI that he can pretty much say, well, you're low on this and okay on this, so you probably have this disorder. But I don't do that, and most people don't do that for clinical purposes. Right. Instead, so docs will often call and say, I have this person, and I don't know if they have ADD or it's due to their head injury. Do they have brain damage? I can't do anything with that. So, because I don't diagnose things. So what is clinical functional MRI? Clinical functional MRI is really, you have a neurosurgeon or a group of people for folks that are going to go have surgery, brain surgery. Right. So neurosurgeons are the biggest referral source, but neurologists will refer as well. And what they want to know is, I need to do brain surgery and resect a part of the brain. Can I do this without harming any kind of cognitive functions? Right. And so then there's some basics on that I'll go through. There's caveats on what we actually map. So the idea is, I'm not trying to diagnose what your problem is, but I know what function of the brain is at risk. And so I map that function of the brain, and I try to find out where it is in the brain, not whether you have a problem with it, it's where it is. So not diagnostic, it's really a map of the brain. I just need to map the brain out, and that's a really big difference. And you can do that on an individual basis for a number of different brain functions. So if you want to go to the slides, I can start showing you some of the specifics so that makes more sense.
Oh yeah,
is this good timing for that?
For sure.
Okay. So clinical is for pre-op, research is for research. Do I have control? Okay. All right. So just to go over that one more way. So research-wise, I do a ton of different research, but I do it with group data. And then for clinical, it's one person and one person only, and I'm trying to map their brain because their brain is the brain that's going to have surgery. So I have some pictures of those in this. Oh, okay. So I'll skip this for now because it's because we've been on a roll. So what I do for functional MRI, the things that you have to think about are, what functions do we map and should we map, and what are the strengths and weaknesses of a mapping procedure like functional MRI or DTI? What can it tell us about the current function of the patient, and then what we would like to do with that? And then are there limitations? So I wrote a book chapter about why a clinical neuropsychologist is a good person to do functional MRI mapping. And it's basically this kind of thing where we're really good at understanding the data limitations based on how are we mapping it, what's the quality control, what's the statistical possibility, and then finally, our specialty of clinical neuropsychology is in behavior. So we test out people's behavior all the time. So we're really used to looking at human beings and understanding, like, do they have weaknesses in this area? Like, how am I going to map that? So what is the bulk? So functional MRI is really capitalizing on this contrast, and this is an endogenous contrast of the brain. So it's unlike when you're injecting people with gadolinium, which is an exogenous contrast in the brain. The bold signal is an endogenous contrast. So it stands for blood oxygenated level dependent signal. Okay. So this is, and we use this thing called the T2 star scan. So this is what it looks like really, really, with better scanning, we actually see more definition. This is kind of an old slide, I think, but you get some better definition, but it's simply not as good as a high resolution scan. But it's that way for a reason, and there's two reasons. And so, first of all, you have to understand that when someone's just at rest, there's oxygen in their oxygenated red blood cells in their blood, but there's also deoxygenated ones. So, so what happens is if you're called to do something, so like say I want you to tap your finger, there's only specific parts of the brain that say, oh, you know, your brain's really efficient, right? So you don't get this huge oxygenation in every part of your brain. You just get it in the parts that need it, right? So when you tap your finger, there's certain parts of the brain that start to work harder, and they have a call for oxygenated blood. And so you get this increase in oxygenated blood. Okay? In that area. So like tapping your finger, it's going to be motor cortex amongst a few other places, but you're going to get increases in oxygenated blood. So the weird thing about the T2 star signal is if you consider what a red blood cell looks like, it has an iron component to it on the heme, right? So that when you're deoxygenated isn't covered. So guess what that is? A paramagnetic effect. And it decreases the signal on this T2 star. Got it?
Nice, yeah.
So what happens when you have oxygenated blood, it covers up that iron, and so it actually decreases the effect on the T2 star. So it decreases the paramagnetic effect. So the signal goes up, right? But the signal goes up not because of the oxygenated blood, it's the deoxygenated blood that goes down, right? So the oxygenated blood is in red, the deoxygenated blood is in blue. So you get less blue, and so you get actually increased signal. So it's really like how much deoxygenated blood is in, and if you understand that, you'll understand it a lot better than a lot of people who actually do functional MRI for a living, because they kind of think it's related to the increase in oxygenated blood, and it's not. It's not. Wow. The signal does not go up because you're increasing oxygenated blood. It's like you're decreasing this paramagnetic effect from the deoxygenated blood.
Wow.
Got it?
Yeah.
All right.
So I guess the signal can be altered by artifacts then.
Oh,
right?
Totally. Yeah. So scanning people with those, the biggest bugaboo I have is those retainers.
Oh, yeah.
Oh, those permanent retainers just drive me crazy. Out, right? However, it blows out the signal in places that doesn't really get all the way to the brain. So you might lose a little bit in the brain, but not a lot. Not too bad. But yeah, shunts. Other kinds of, we can scan shunts, but you'll get this big artifact. Right. And that's really important. And I'll bring that up. Other things that are artifacts are things like vascular lesions, right? Right. So I have to spend a lot of time deciding if we lost signal due to that. Right. Okay. Right. But so this is the signal. So the reason why T2 star works is not only is it very, very sensitive. You guys know that T2 is really sensitive to those paramagnetic effects, right? More than T1. Right. But the other thing is we can collect these data really fast. So they're not beautiful pictures, but they're collected in 2 or 3 seconds. That's what we generally use. You can even do functional MRI at a faster rate, but we generally do 2 to 3 seconds. So every 2 to 3 seconds, we can get a whole brain. Wow. Right? Yeah. And the slew rate's better on 3T now, so we can do it. We can get a lot more slices. Ooh. So we can go to a smaller slice thickness, maybe 2 or 3 millimeters. I usually use 3 millimeters, but it used to be that people use 5 millimeters, right? Because they couldn't get through the whole brain, right? Because the slew rates weren't. Right? The slew rates weren't good enough, and 1.5 needed the extra power. Okay. So 2 to 3 seconds is much more closer to the way your brain is working than, PET studies, which I didn't go over, but, they need to collect a whole bunch of radioactivity in order to get signal for cognition, right?
Right.
EEG is better than this because you can get down to milliseconds.
So that's actually, I'm glad you brought that up, because how many other ways is there to map
Okay,
the
so
function of the brain?
all right, so here's my wonderful slide. I'm very, very attached to this slide. So what this slide is a bunch of different ways to measure functional brain. So, I use that word because functional MRI somehow or another got attached to what I do, which is that bold signal.
Mm-hmm.
But there's other ways to measure brain function with even MRI, right? SPECT,
Right. Oh, yeah.
right? Because
sure.
that's brain function. So is
true, yeah.
perfusion.
Perfusion, yeah.
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 So for some reason we hit the jackpot and we got the word functional, but for some reason, so functional MRI is attached to our word, but all these other things can measure brain function. But let's just stick with let me just organize your thoughts. So when you do research, you really have to be aware of what the limitation of your scanning or your data measurement is. So there's spatial resolution and temporal resolution. And then there's also brain resolution, which kind of maps with spatial resolution. So if you think of somebody getting a lesion in their brain, like somebody has like a stroke or something,
Mm-hmm.
you can get a really gross distribution of where that stroke is and understand how it affects function. But it takes time, because you're measuring out people's abilities. And it also is pretty much, high in terms of, you're going to get gross distribution.
Right.
So the other thing are these like single unit recordings. So we can take epilepsy patients and put electrodes in to find out where the signal is for the focus of a seizure is.
Yeah.
Well, people actually get information too about function of people's brains because that's like an EEG, but it's very, very, it's a single unit EEG. So there's research studies about, what series, like number of cells fires when people do a task, but highly invasive, right? So it's got good spatial and temporal resolution. But anybody here want to get a research study going where they stick electrodes in your brain? Probably not, right? So you're not going to do that. So this is a sweet spot for scanning, right? So because there's what we call it is a good spatial temporal trade-off, right? And of course, it's got that fourth dimension, the invasiveness. So PET, not so great with the invasive part, right? Because it's radioactivity.
All right.
So it's really great for certain things, but in terms of the cognitive side of things, which is what I'm doing is behavior cognitive, it's not as good because it takes time for that signal to pool. So you put someone in a PET study. Early studies did use PET because functional MRI came on board after PET, right? So using FDG PET, you can put somebody in a scanner, you can have them do something, and after a while, you'll collect enough data in certain areas of the brain. But the resolution is not good, and the timing isn't really good.
MRI is just the best, right?
Yeah, so functional MRI has a really good trade-off on that. EEG doesn't have as good a temporal or spatial resolution as functional. Okay, and this is like a huge box, but I would say that functional box has gotten into, a few, we're much better than we're in millimeter level, not in centimeter level. Okay. So I love that slide because especially when I'm teaching people, I want them to understand that there's strengths and weaknesses of all of these things. And we just try to you just have to interpret your data appropriately.
I just never knew there were so many different ways.
Oh, yeah.
I didn't either.
Yeah.
Wow.
There's even more than this, but we'll just leave it at that. And then this is just another thing about the functional brain mapping techniques. So I do some of these like electrical cortical stimulation of the brain. We can stimulate the brain, and that's what we do when we do a wake mapping. So when I go into the surgery and the neurosurgeon uses an electrode to kind of temporarily stun some part of the brain, and the person can't talk, well, that's electrical stimulation. Obviously very invasive, right? And I also do these things called WADAs where you put half the brain to sleep very, very briefly.
Ooh.
And so you you put a catheter through the femoral artery up into one side of the brain, and then use a chemical that briefly puts the brain to sleep.
Oh.
And then you look at what the other half does.
How do they have to shunt off the communication between the brain? How does it just
if
get
you put
one
it
side?
in right, it goes in.
That's so interesting.
Yeah.
WADA. What is that?
Yeah, that's well, WADA is the name of a person who did it. It's really called the intracarotid it used to be called the intracarotid amobarbital test, but we no longer use amobarbital. If we have time, I'll tell you why, because it's an interesting story.
Yeah.
So anyway, then you can see PET. It says spatial resolution of 4 millimeters. I don't believe that. It's probably bigger. And then ours is like down to 1 millimeter. And here's MAG, which is magnetoencephalogram, or I said that wrong, but anyway. And then DTI is tractography. So we're gonna spend time talking about tractography and functional MRI. Okay, so this is the bold contrast. This is what it kind of looks like. So this is low in the brain, so it's really pretty pixelated, and it's just this is a post-processing tool that I created in MATLAB. So
nice.
So it's the reason why we created this is because you can look at each voxel. So this is a voxel, this is a voxel. This is like 9 voxels.
Oh, I see.
So this
Within
little
your
square, is 9 voxels. So you can see what every square looks like. So this person was seeing visual scenes or a crosshair. And so every 3 seconds, they saw some visual, or every 3 seconds you collect a volume of the brain. And then for a chunk of time, they see scenes, outdoor scenes, or they see a crosshair. And so basically what we're doing is a statistical question. We're saying where in the brain is there more activity when they're doing what we think they're supposed to be doing versus when they're not.
Right.
Okay. So this voxel clearly would not pass muster because there's no correlation there. But you can see the correlation's really nice. So I was mentioning this, but if people scan on a GE scanner and they do real time, GE is really good about showing. I mean, you can kind of see real time on all of them, but GE is just the easiest. Not to do a brand. I mean, all of them do it. It's just a little bit trickier to kind of set it up. But real time in GE land is really easy, and you can just see on-off cycles for something as strong as vision. For other things that are more complex, like language, it doesn't show up this strong. Vision's just super easy to map because your brain wants to input that data.
And you talked about it briefly, and I don't want to jump around, but I'm so interested in how you do your task.
How do I set up my tasks?
Yeah, like how do you know that a certain task is going to get you the results?
So I think that's even kind of what I have on the screen.
Oh, nice.
So language, motor, vision, those are the main things that you're going to map for clinical purposes. Okay, so the reason for this is a fewfold. All right, so when neurosurgeons need to take parts of the brain out, there are certain things that are more important than others, right?
Right.
So what's classically been the most important things are motor functioning, language. Like they need their patients, they don't want to create a deficit that in quote unquote eloquent cortex. And eloquent cortex from a neurosurgeon's point of view are these things that are going to really mess you up. All right, so vision isn't necessarily mapped in a lot of people because you can live with a visual deficit, right? Like you can live and function pretty well with a visual deficit. So that is mapped when people are extremely high functioning, maybe need their vision to a really high level, and then also their lesion is not such that the neurosurgeon kind of needs it to come out. So let me explain. So you have a brain tumor. Brain tumors, especially high grades, you really need to get out as much of that brain tumor as possible because it is correlated with how long you'll live. All right. So that is a quality of life thing, right? Your length of life.
Right.
A huge quality of life.
Pretty big deal. Yeah.
Right. So if language though is near that, and neurosurgeons oftentimes want to get a margin around what they can see on the scan. So, post-contrast scans, and when you see it bright on the T1 post-contrast, that's lesion. All right, that's a GBM, right? So they know for a fact that the vascular system is broken down, and that's why you get that leakiness of the brain. and you get that lesion.
That
Okay.
Yeah.
They want to take a margin around that, because just because you can't see that there's tumor in that infiltrating, area around where you see the contrast change, there is,
Right.
right? So the more you can get out, the longer people have till the cells come back and recur and the person's in trouble again.
Right.
Okay? Well, if it's in parts of the brain that the neurosurgeon knows in general is involved in language, then they want me to map their language function, because they do not want to take out parts of the brain that are going to cause a language disturbance, because people can't function, right?
Right.
So there's these other papers that show, like, if you get if you sustain a major language disturbance after surgery with brain tumors, your quality of life is lower, and you might not live as long, just from all these other factors.
Right.
So in general, neurosurgeons want to do as the least amount of damage as possible, of course. So, and they also want to be able to talk to their patients and explain the risks and benefits of surgery.
Mm-hmm.
And so they use these brain maps, okay, for this. Sure. So that's why the neurosurgeons are very interested in mapping these things. So vision is mapped sometimes, but sometimes vision doesn't move. The other things, okay, but before I say that, memory is also an extremely important factor.
Right.
But we don't know yet. There's not a really good memory task yet that we can use clinically. Like, there's a research study I was just looking at that does a memory task, but memory is really complex and really hard to nail down versus vision, which is super easy, and even motor's pretty easy. Language is more complex. Vision is way more complex memory is more complex than.
Right.
So
when you say complex, you mean like if you are doing a memory task, it might be different in every patient?
Yeah. So think about and where it's distributed in the brain. There's
and short term and long term might be different.
Well, short term memory, I don't think we're going to map. What we're really trying to do is, there's this famous patient that got both of his hippocampi taken out, and his name is HM, and he died recently. But HM, and they did it for epilepsy purposes, because he had seizures. So they took out, this is back in the 50s, before they knew anything about the memory system to the extent that we know now.
Right.
Took out both of the hippocampus, and he had just massive memory deficits. So for instance, you could be his doctor for years, and every time you walked into the room, it'd be like he was seeing a new person. He had a very, very, extremely hard time understanding or remembering people.
Right.
All right, so that's because the hippocampus consolidates your memory. Okay, that's what I'm trying to map. Because we still have people with hippocampi. We need to know if the other side is okay. That's why we put half the brain to sleep during the WADA. Because you put half the brain to sleep, and you see whether their memory works on the other side.
Oh, nice. Okay.
Does that make sense?
Because that's the only other way of pretty much determining what side, what side's doing the work.
What you're trying to do is, if you need to take a hippocampus out because people have seizures, or they have a tumor, or they have something there, you want to make, if you're a neurosurgeon or his medical team, you want to make sure that the other side is working okay.
I see.
So you need to know that the other side is working all right before you take one out.
Yeah,
right?
That makes sense. Yeah.
Because if the other side isn't working okay, then you have to, and the person can remember things, then you don't want to make them worse. Right? So the whole key of my brain mapping is to not make people worse than, to just mitigate any kind of deficits.
Bet the
Preserve what
neurosurgeons
they
love
have.
you, right?
Well, so I take my job extremely seriously, because
Sounds like you should.
Yeah.
Well, because patients, I really love patients, and I want to do the best I can. So I talk a lot with the neurosurgeons about the risks and benefits. So we already talked about the fact that I don't do diagnostic, right? So let me show you an example of really how we do brain mapping. All right. So this, and if I didn't answer your question, just remind me. So just like all neuroradiology, left is on in the right side, right is left. I keep it in that. So individual differences is this phrase that I don't like very much, but it means that we all have slight differences in how things are organized.
Right.
the best version of that is lefties. So people who are left-handed sometimes have right hemisphere language. Sometimes they have left. The majority have lefts, just like everybody else. But sometimes they have right hemisphere. I'm a lefty and I have right.
What if they're ambidextrous? Does that cause problems, or is that a real thing?
Okay.
The real thing.
This is my favorite thing. So there are two things that people are overly, and you guys probably notice that one of them. Two things that people think they are that they're probably less likely to be. One is ambidextrous and the other is claustrophobic. How many people do you know that they're like, I'm totally claustrophobic, so you as techs have to ask, can you get inside an elevator? And
you
they're
rode
like,
the elevator up here.
And
Yeah.
so,
Right.
So everybody thinks they're claustrophobic to some degree,
Right.
and we usually have to kind of just work through that, right? Well, ambidextrous, like anybody can be ambidextrous, right? Like you can teach yourself how to throw a baseball or bat left-handed,
Right.
easy. That's not what I care about. I care about what hand do you use to write
What's
with.
your primary, right?
With right, because that's language, right? When you're
Right.
writing, that's language.
Oh, yeah.
So that's all I care about. So people tell me they're ambidextrous all the time, and I'm like, which hand do you write with?
I don't care what you
And
throw
most
football
people
with.
have a hand that they write with. And then you say, and some people get kind of, shirty about it. And so they're like, I'm ambidextrous. I'm like, okay, write your name. And it comes out all weird, with their non-dominant hand.
Right.
It's a good point.
But-
I never thought about that.
Right.
But most people, but I mean, it's really some people do, because people rightly so use their right, like I cut scissors with my right hand, but I am so left-handed because I never had left-handed scissors when I grew up. So like everybody's a little bit ambidextrous, but what I'm using it for is solely to figure out where their language is probably in the brain.
That makes
Now,
sense.
do you want me to tell you like an anecdote, like one of my favorite
Oh,
anecdotes?
yeah, for sure.
So both myself and some of the neurosurgeons I work with are really we really do ask about handedness a lot, because I had this case many, many years ago of this woman who came in and she had a right hemisphere lesion near where language would be. If you were a lefty, some lefties, not all lefties.
Mm-hmm.
And she said she's right-handed, so she had surgery, and she comes in, and I'm working with her, and she's really impaired, language-wise. And because I couldn't figure out why the neurosurgeon sent her, but she's really impaired. She needed more surgery, so I was there to map her language. So I'm talking to her granddaughter who came in with her, because I used to have people kind of sit and talk to me while I was scanning their patients, so I could understand more about their loved one and kind of integrate that in my report. So anyway, she's like, I don't know what happened. So she's like, well, my mom's in the waiting room. I'll go ask her. So it turned out that this woman had gone to a Catholic high school or Catholic schooling, and the nuns were really strict about, and I think other teachers too, but they were really strict and didn't want people using their left hand, so they taught her to use her right hand. And so she grew up using her right hand to write, but she was innately a left-hander.
Oh, wow.
And so when the doc asked, are you right-handed, he didn't go into any more detail than you're right-handed. Didn't think that, because language in righties is almost always in the left hemisphere.
Right.
And functional MRI was just coming on board there, so we didn't use it a ton like we do now. And so he just did surgery and she got a deficit. So now when people say they're right-handed and they have a right hemisphere lesion, I'll say, are you really, 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 really right-handed? Nobody tried to change you. And I get,
are you Catholic?
Every once in a while, people go, oh no, well, actually, the teachers did tell me I had to use my right, so it happens. That's a little anecdote,
So funny. Dang.
So anyway, this patient was left-handed, knew they were left-handed. So the neurosurgeon, and they have a lesion in the part of the brain. It's called the, So they have a lesion in part of the brain that's called the left inferior, or the inferior frontal lobe.
Mm-hmm.
You good? Oh, no. Okay. So in the inferior frontal lobe, so it's right there. So see that? That's a contrast enhanced scan. So that is a brain tumor. Right? You see that right there? Well, so I mapped this person's expressive language abilities, and sure enough, they have right-sided language, and look how close it is. So that's why
Wow.
they want me to map,
That's awesome.
right? Because it's right on the edge. Brain activity associated with language is right on the edge. And this poor person, like it's not very many people who are left-handed that have right hemisphere language dominance, but unfortunately that person does, right?
Right.
So they got really unlucky. So sometimes I'm really very pleased to do this because the person might be left-handed, they have a right hemisphere lesion, and I can say, oh, no, it's all in the other hemisphere. Go,
You're safe. Go for it, right?
And so that person's going to be prepped up by the neurosurgeon much more differently than somebody like this.
Wow.
That's in a nutshell. So that's a big, huge individual difference.
Right. How does the neurosurgeon use what you give them?
All right. So I have
Yeah.
a picture of that. I'll just flip to that and then I'll go backwards. I don't know where it is. Oh, shoot. There. All right.
Oh, okay.
So this is neurosurgery. Okay. So this is a neurosurgeon. This is DTI in there, and we'll talk about that in a minute. But we just went light years into doing neurosurgery when they came up with something called Neuro Navigation.
Mhm.
All right. So lots and lots of centers around here use the Medtronic Stealth system.
Oh,
There's
yeah.
others called Brain Lab and there's more vendors,
Right.
but this just happens to be the Medtronic system. And so this is the coolest thing. So you know how you're doing scans, pre-surgical scans,
Mhm.
and then people go to surgery? Well,
Right.
those scans that you're doing, the reason why we get all anxious about no movement, all that kind of stuff, is because you're used up in the OR. So this is an MRI that was taken several days before this person came to surgery. And that's been a huge, remember when
so
you
they're
used to
lining up this
Right,
person
so-
in real time with our
right.
images that
So
we
that's
took.
called neuro navigation. It lets you
Oh.
navigate based on the MRI in the person's brain in real time. So remember do you have a question?
Well, I was just going to say that's probably the reason why we want to make sure that we scan a straight axial so it's
Yeah,
reproducible.
it
and-
used to be, and it's generally considered, I'm old school. I think they're changing it now, but like
Mhm.
straight axials are better for getting registration. At least they used to be. I think the companies are coming up to speed on that.
Right.
But remember when you used to do fiducials?
Oh, yeah.
Mhm.
Right?
The little
And-
donuts
and-
on people's heads?
Yeah, and you used to, and there's and they still do it for radiation purposes.
Mhm.
Well, this is fiducialist. All right. So this is why you have to get that extremely pesky nose. Because what happens is obviously the inside of the brain is not available for doing registration.
Right.
But what they do is a 3D construction of their face. And then they use all these spots, their ears. That's why I don't
Right.
like
depressing
headphones,
the ears.
because it changes, the headphones change the skin
The
around the
profile, huh?
ears,
Yeah.
the nose, all of that information is used. And what happens is they just have this 3D, they have this locator system that allows them to triangulate and in real time line up this scan with the patient's head.
Nice.
And then this is called we call it a wand. It's got it's a probe that neurosurgeon is putting in the person's brain right here. See that right there?
Oh.
There is some shift because obviously when you open up the person's brain, there's shift, right? Because you can see there's no, this is a pre-surgical scan, right?
Right.
So there's no holes in their head, right?
Right.
There's no opening of the cranium, but clearly he did, right?
Right.
However, this is why those scans are so important.
Right. And does it get a big alert if something's misregistered? How did it? Is there some kind of safety?
Well, yeah. Right, and they struggle with that, and we try to do all sorts of things to make sure that we can, And the neurosurgeons, though, these are people who do these surgeries for breakfast,
fine
lunch, and
movements, right?
dinner, so they understand shift, right? Because that's what it's called, brain shift, right?
Oh, right.
So they understand, and that's but at some centers. There's something called intraoperative MRI.
Oh, yeah.
And so intraoperative MRI is when the neurosurgeon is taking out a lot of the tumor, say, like, so this is the tumor right here. So say they take that out, right? But they want to make sure that they got everything that they wanted to get. Well, after some point when they've done enough surgery, this isn't gonna stand anymore, this kind of registration.
Right.
So they'll do a intra-op MRI while the person's still kind of in the surgical theater enough that if that surgery, or if they see that they can take out more, then they can do more surgery. They have a new scan to calibrate to the person that takes into account all that shift, because it is the brain.
Right.
And then they can do more surgery.
Yeah, that just seems like a game changer, because like how you were talking about earlier, how important it is for them to get as much out as possible. So if they need to go back in and finish up, getting a little bit out, it extends that life so much longer, huh?
Exactly. So how does my work play a role in this? This is tractography, but it's functional MRI looks the same in the scan, just a different color, and it's not going to be that deep because it's cortex, right?
Right.
So, but this is a perfect example of why it matters so much. So this is the cortical spinal tract. Okay, this is the part. If you want to move anything, right? You want to move anything, this is the white matter that lets you move it, because it goes from your motor cortex down through your brain, down into your spinal cord, exits out where it's supposed to exit, and you can move part of that body. Okay?
Right.
So you can cause people to have a major motor problem by removing the part of the brain that controls that, or cutting the white matter that controls that. Right? Right? Or having, doing the same thing in a spine.
So the tracts are pretty much the nerves?
Yeah, they're the nerves.
It's
so so it's white matter nerves. Okay? So if you see this, you can tell why this neurosurgeon really wanted that information. That's very helpful for them to know how far over they can come before they start getting close to that white matter tract, which they will not intend to ever cut. Right. So they want the most information. So this is why it's so absolutely important that I do a good job in mapping these things, right? Because this is serious, and the neurosurgeons really need good data. So let's go backwards, and I'll show you some more fMRI. All right. So nowadays, it's been really controversial. There's many sites, and there's some people who just don't think it's useful at all. Right? Because we were kind of, like you said, it's kind of a new procedure. So there's still a lot of controversy over, controversy is not the right word. There's just neurosurgeons who are like, nope, this isn't going to help me. And other neurosurgeons who are like, I really need this information.
Right.
And I've been pleased, because some of the neurosurgeons, I actually think it's really helpful and important in many cases. And it's kind of nice to see neurosurgeons who are kind of in the former category become in the latter category and actually think it's helpful. So there's research now to show that it decreases, like the information that you get can help to decrease mortality and morbidity in brain tumor patients. So things are being published that say that. So what do I really help with? All right. So this is a T2, right? And you can see the huge lesion right here. T2s, if you get all of that out, then say it's kind of associated with a low-grade tumor. And oftentimes those people can have long lives, like high-grade tumors are a little tricky, but low-grade tumors, people can last for a really long time. There's a little bit of motion, see that? But anyway, I won't quiz you on all the brain parts, but I could.
Quiz Reggie.
Yeah, there you go. All right, so Eloquent Cortex. This is an example of two parts of Eloquent Cortex.
Right.
This is motor functioning. This is where lip functioning is, right? So that's the lowest part of the motor cortex, and this is language. So this is expressive language. This is comprehension. So you take that part out right there, and the person won't be able to comprehend. Like, they wouldn't understand this podcast. They couldn't follow. And people can be walkie-talkies, right? They can seem like, to the doctor, to the physician that they're doing pretty well, and then I find them to not really understand things very well at all. You guys have probably experienced that.
Right. Does that come off to them like we're speaking another language, or they just...
Well, so it's really interesting. So an example of this was this incredibly bright person that I scanned who I think she was a writer or something. She had some sort of, wow. She was verbal, right? Mm-hmm. So she goes to the doctor, and when you go to the doctor, you can pretty much tell what the doctor's going to ask you to do, right? Stick mm-hmm. out your tongue. So you understand the word tongue, and you stick out your tongue, right? But you might not hear stick out your tongue, but you know what they're going to say.
Right.
So she could really talk about her disorder really well, like, well, I was doing this and I found that, and she could verbalize that really well. She could follow certain commands. But then, and so I was kind of fooled by her, but then I started asking her specifically to do my tasks, right? Because, mm-hmm. As you guys know, because you are near me when I'm practicing with patients, right. I practice with all the patients beforehand and make sure that I understand their level of impairment or mm-hmm. intactness. And I have to describe what I'm doing because it's so different than a regular scan that people really need to know what we're doing. Mm-hmm. So basically this woman, I was just kind of having her do a fluency task, and I wanted to say, so I asked her, okay, so like pretend, like tell me all the things you can that are food that you would eat. And she looked at me and she goes, tea, I drank some tea, because in her mind, she didn't understand why I would be asking her about that, right? Because it's not something she's going to do. It's not something a doctor asks. So suddenly I had gone into this realm, and she doesn't really understand that, because I had said, okay, we're going to do a task where you're going to say all the words that you can. So like, let's practice, tell me all the things that you can that you can eat, because that's usually a way for me to figure out how fluent they are and whether they can do that simple task. And she couldn't do it at all. Wow. So she couldn't understand that.
Wow.
Right? So like, if you don't ask them in a certain way, you wouldn't know.
Right.
Right. So that's why I think clinical neuropsychologists are really good at doing functional imaging like this, because we work with patients all the time and we can suss out when somebody's kind of not going to be able to do it.
Right.
So I have a lot of step down tasks. I still could map her, but I had to seriously back off and do easier tasks than I was prepared to do.
Dang.
Right?
Right. Dang, what would be easier than naming the foods that you eat?
Oh, well, she didn't really need that because she needed comprehension. So I figured out, so instead of showing her things that I had to practice comprehension a lot with her and figure out what level she could read.
Oh.
Sometimes I have people read whole paragraphs, sometimes just sentences. And if they're really impaired, just simple words. And, I do a lot of different things.
Right.
I
see your playbook.
Yeah, I'm always changing things up and that's sort of a difference between me and maybe some of the other ways it's done when technologists do it. They have just a playbook that they don't really know where the patient's at, and they just do them all.
It's just like vendors, right? Like a preset vendor playbook.
Yeah.
And we just... select one of 5.
Yeah.
tasks.
And it's very helpful a lot of the times, but I probably have more play. I think the neurosurgeons have just infamously sent me people who are incredibly hard to map. Right. Like the person's, I need to know their motor functioning and the person cannot move. Those are always tricky ones, So like, I think I have a bigger playbook of things that I can do because I'm used to working with patients.
Right.
But so like what they want with this. So this is oh yeah, sorry. So this person in the blue is 2 types of language. One is expressive language, and that's way far away, so we don't have to worry about that. But this is that comprehension that we were just talking about. And then this is part of the motor cortex, right? Mm-hmm. So the neurosurgeon is both wanting to figure out sort of how much they can take of this lesion. But part of neurosurgery, as I've learned of working with them, is they're trying to find the smallest amount of good tissue they have to go to get to a lesion, right? So they're looking for the smallest amount. So trajectory is the word that comes to mind. Right. So they will change their trajectory depending on what I find to be eloquent cortex.
Right.
Right. So like clearly this would be nice for, but they're not going to do that. Right. These are tracts or like you said, like axons or white matter that is associated with language. And then this is the cortical spinal tract. So you can see that I can put all that data all together for them so that they can understand that. So they're going to be watching this area over here. They're going to be watching this area over here. And they're going to figure out a way to get in that doesn't interfere. And all of these data are up in the OR for them. So they can look at it before time on the PACS, right. And then they can look at it and then they have it real time in the neurosurgery suite.
Wow, that's
amazing. Is their ultimate goal is to map all adjacent tissues? So like,
well, no.
I see things.
Yeah, thanks for bringing that up. So Eloquent, that's why the Eloquent is in red, is we could map, well, so visuospatial abilities. Mm-hmm. There are some differences of opinion, I think, out there for people who like to do brain mapping. I'm a clinician I work with like 30 neurosurgeons. Right. I mean, I have them all on speed dial because they're very nice to respond to me. And they've also been really good over the years for me to really develop an understanding of what is important to them and what is not. Right. Messy views are terrible for them. They don't want to see everything. I had this one neurosurgeon who was a man of few words. Very few words.
I think I knew him.
Very few words. My favorite story about him is one time we were meeting and he just said one word. He said brevity. Like he didn't even say, I want this brief. He said brevity. Oh, right? Very few words, right? So I used to map all the time, both hands. Like this is where they tap with the left hand and this is where they tap with the right hand. And he's like, side of lesion only, right. Like they don't want, because it's really messy up in the OR if you have all these brain blobs floating all over and they have to figure it out. So I try to map what they need and nothing more, right? Nice. So to get back to your original question, what's eloquent? All right. So some people might think visuospatial abilities are really important, but we're language-based people. If you lose your car in the parking lot, first of all, you can still function because half the people can't find their car in the parking lot and they're perfectly fine. But what we really do is we can compensate more for visual spatial functioning. And we don't need to communicate with communication with your caregiver is of ultimate. Like you lose your language and you lose something really huge, right? But if you lose your visuospatial ability, then you just use verbal cues to figure out, like, oh yeah, I turn left at the corner, right at that, I turn left at street X, and the word left, and street X, and you pretty much can do it. So I don't map everything. Right. I map what's important and what the neurosurgeon, there is a bit of a, like I don't have visuospatial tasks, so I couldn't map them. Mm-hmm. The other thing about language is I'm very careful to explain to the patients, especially high functioning, what I am mapping and what I'm not mapping. So these are very broad abilities, the ability to comprehend what's going on. This is not like naming is all over the brain. So naming is affected by like medications, seizure medications, other medications, radiation, chemo, everything affects naming. So I do map naming in this one part of the brain that's critical for naming, but basically it's hard to map that. Yeah. So not everything gets mapped. Okay.
Nice.
So I'm just going to show this to you just to say, like, this is actually one of the printouts of somebody who got mapped by a technician-based system. And so the other thing about being a neuropsychologist, and I really understand all aspects of functional MRI. So there's, like you guys said, I know how to scan. Right. I know what the TR is. I understand field of view. I understand, how big my voxel is. I understand all that kind of stuff. I understand the cognitive tasks and the functional neuroanatomy of the brain. Mm-hmm. I also understand statistics and how I have to make sure that my data are real, but not. And then what I really understand is what the neurosurgeon needs to see. Right. All right. And so when I was early on and I was a researcher becoming a clinician, my maps looked kind of like this. But as I said with my brevity neurosurgeon, this kind of stuff is not super helpful for them. Right. So over the years that I've worked on, that right there is motor functioning, right? Well, where is it supposed to be? They need to know where the gyrus is, right? So this is the premotor gyrus right here. Mm-hmm. So if you look at, this didn't pop up right here. Let me see. Oh, whoops. Underneath this is a better picture, but you can see that my tasks map, that's a motor task right there, and that's where the motor cortex is. So that tells them exactly where it is. Where is it on this big blob? I don't know. So I've learned to really adjust what I do to really accommodate the neurosurgeons. Right. So this is the motor cortex. Motor cortex doesn't really move around very much like language does. So but when the brain has a tumor in it, it distorts it so much the neurosurgeon can't figure out, is it before this, is it anterior to this tumor or posterior? So they want to know, and is it this gyrus or is it this gyrus when you kind of lose that beautiful kind of hand knob area? So you can see mine I still have like kind of a blobby shape for it, but it's way more specific than this would be.
Right.
We wouldn't be able to.
Do the colors mean anything?
Colors, so they're just mapping all these language maps, and you remember what my language looked like? Like this is, I can't figure out what this means. So I spend a huge amount of time trying to figure out how best to describe my data for the neurosurgeons. I also talk to them a lot and just make sure that they understand what the limitations of the data are.
Right.
So that kind of comes up when I do DTI. So this is DTI. So functional MRI maps pretty much cortex and brain function that way, and then DTI maps the white matter tracts that line it up. Like we talked about the cortical spinal tract, right?
Right.
So motor cortex, this is motor backwards. This is motor cortex, but you could leave that and then cut the DTI, and you're still going to get a motor deficit. Okay. So you got to pay attention to. So now we do these side by side, same exam, along with the high resolution pictures, and then I overlay them all because we collected all that. All these data are collected at the same time. Okay. So this is what DTI looks like. I could tell you about DTI a little bit, but this is what you need to know about DTI. It's still a time-based scan. Mm-hmm. So you collect data over a course of time, and what it does is it labels the water molecules in a certain way, right, so that over the course of time you can track those water molecules as they flow. Okay. So what happens
their
is
their direction of flow, or just
both where they are and where they're going.
Oh,
and
nice.
And so but what you're also doing is how much flow there is. All right, so this is the big bugaboo. when you think about a proton in a water molecule, if it's in gray matter, it's pretty well stuck where it is, right? So you can knock it down and have it travel, and it's just not going to travel because it's compartmentalized in tissue. Right? Or extracellular fluid, which is usually pretty packed in.
Yep.
CSF, it can go wherever it wants to go, right? But white matter, it's what it is doing is, if you understand what white matter is, it's tracts have a myelin sheath on them, and that's fat. It cannot flow across that. Water doesn't flow across fat. Mm-hmm. So what you're really measuring is when you have a tract, like a whole bunch of fibers, like axons together, and they make up a big tract, water's trapped in between those myelin sheaths. Okay? Right. So it's kind of there. So it can move, but it can't move out. It can't move across those myelin sheaths. It's going to move along it. All right? So it's moving right along, and so that's called fractional anisotropy. So isotropy is you drop a drop of oil in a big jar of liquid like water, it's going to go any direction. So there's going to be vectors going in all directions because these things can go. It doesn't matter where it goes.
Right.
If you travel, but if you're in white matter, you have a tract, and you're gonna. So it's anisotropic, and so you're gonna have a vector in a certain direction. In it's going to be bidirectional, right?
Right.
But it's going to be so like if you have a tract and water's moving along it, the vector is going to be strong because there's lots of movement,
right.
like the CSF, but it's also going to have a direction to it. All right, because it's not going to go up this way, it's not going to go down that way, it's not going to go that way, because it's surrounded by myelin. It's going to go that way.
Right.
So that's why, and that's called fractional anisotropy.
I know, say that 3 times fast, right?
Yeah,
I can say it 1 time fast.
Yeah, I can say it really fast. I can say all these things really fast until you're on the air, right?
Right.
So anyway, it goes really, really fast, or it goes so it moves,
right?
And so FA is high in white matter,
right?
So DTI, these are little pictures of little voxels. And what they did was, so this is a picture of a voxel, right? So it can't go this way because it's going to hit white matter. It can't go this way because it's going to hit myelin and white matter. It can go, but it can go this way, right? Let's just say, all right? So they colorize that direction. But it also is a 4-dimensional pixel, right? Because so it's got an FA. Mm-hmm. And then it's got a direction. Right. So when you run DTIs, you'll notice. So a 3-directional is just your typical
like
what do you guys?
Diffusion?
Yeah, it's just a diffusion weighted,
nice.
Right? Because you're looking at how much movement. Yep. Because strokes
diffusion.
You get and if you read they'll say it's restricted movement or restriction, right?
Diffusion restricted.
Yeah, diffusion restriction. That's how you figure out a stroke, right? Well, we take that we can do this in normal tissue, and we just take it to the nth degree because we add in, instead of just 3 directions, X, Y, and Z, we add in a boatload of more.
Right.
Okay, so 20 directions, 32, 64, 128.
Right.
And what you're doing is just getting a finer and finer line of just how much, what the direction really is in that voxel.
Do you remember what direction this one was? How many directions?
This is, I don't even know where I got this. This is probably a 20 direction one. Okay. We use 32 mainly. Mm-hmm. So clinically, for research purposes, people want more and more directions, and they'll do 2 versions of it so they can do these funky analyses. For clinical purposes, time is, we have time issues, right? Patients start moving.
Right.
We need these to be as cheap as possible, so we can't have people in there for 3 hours for one scan.
Right.
So we don't want to. So we usually can collect about in 4 minutes a reasonable amount of data with like 32 directions. So what we do is I do something called tractography. So I take it offline and I have a program, and I can isolate tracts that have certain qualities. So the FA is high enough so I know it's still white matter. Mm-hmm. And then it's got a direction that I expect it to go. And basically there's this seeding program that takes math and calculates, like, is this voxel here associated with that voxel next to it based on its FA and its direction. Oh. So if it takes a 90 degree turn, it's not the same tract, depending on what I decide it's going to do. So this is just kind of showing you how a tract gets isolated. So this is all that data that has directions. Ooh, you think it'll run? Yeah.
Oh,
so it's got directions. So it's all the voxels in the brain.
Oh, that's cool.
And so you get all that data, but then boom, you can isolate one tract. And that's the cortical spinal tract.
Cool. So depending when you put your seed 1 or seed 2 or whatever. Yeah.
So it's cool. They're trying to move to programs that are automated.
Oh.
I've been involved. I'm a consultant to some of these companies, and they're getting closer, but they're still not there. But again, this is why it's really important to have somebody who knows what they're doing make these tracks.
For sure.
First of all, once I had an engineer who thought it looked great and was sending up like all the tracks in the brain, and I'm like, the neurosurgeons don't want to see that. Like, can you imagine being up in the OR and just have all these tracks in the brain?
Gosh.
You need what you need, right?
Right.
So my job is to do that, but it's really rife with difficulties because you're drawing things. So you can draw a little, like, you can miss things or you can do too much. So what I do is I'm very conservative, right?
Right.
Because there are two risks. So if you're in research, your risk is saying that something is occurring that really isn't. So you usually have this true positive problems. You don't want to say something's truly positive when it's negative, right? So there's an alpha error problem. Well, in brain surgery, I'm worried about the exact opposite, that I said something was negative and it actually is part of it. So you have to be conservative the opposite direction because you don't want the neurosurgeon to think that some part of the brain is not functioning and then they take it out and the person has a deficit.
Right.
So I am conservative. Sometimes like these programs have cropping things and techs do it and they say, oh, it looks prettier if you take that out. And I'm like, no, because you don't know whether it's still functioning. All right. So this is what it looks like in terms of it. These are three. So you can see like this is supposed to go like that right there. But this brain tumor has bowed it way out. So you can see why the neurosurgeon would want to know about that, right? Because it had an equal chance of bowing it out that direction. Right.
Yeah.
So did it splay these things out that direction or this direction? So not only do the neurosurgeons get this basic idea of like, okay, motor system anterior to the lesion, but they also can look at it in 3D and as they're doing surgery, see how close they're going to come to the cortical spinal tract. Okay. So the one thing I wanted to say about quality control and like knowing your underlying data and understanding what these techniques do is, look at that. That is a huge. Do you guys know what that is? That is. No, that's an AVM.
AVM.
It is ginormous, isn't it?
Yeah. Oh my
well, guess
gosh.
what? T2 scanning in an AVM doesn't work, right?
Oh. Right.
Right?
Oh, yeah. Well,
because
we
of
talked
blood.
Before. Yeah.
Right?
Yeah.
Because it interferes with the signal.
Exactly.
So see this right here? This is the underlying, this is DTI data, and this is the underlying data. It's not there.
Right.
Is it not there because it's not there? Or is it not there because we can't see it because of our signal? That's why you have to know what your scan is doing.
Yep.
You have to know what your scan is doing. And that's why I spend a huge amount of time sweating this kind of stuff. Because
That's
what
tough.
the neurosurgeons get is this picture, right? And the neurosurgeons, many of them are very savvy to things, but they're not really savvy to signal dropout, right? I mean, some of them are, but a lot of them aren't.
Right.
So they don't know that this is just missing data. Like, see that? That's missing data. It's fine over here. So who's to say that there's not tissue that goes all the way out here and it's just not good for DTI, right? So I show them these pictures and I had this one neurosurgeon, and I tell them all the caveats. Like, look, this is, the cortical spinal tract's on this side, but I don't know how far back it goes into this AVM.
Oh, right.
Right. And I show them, and I have a lot of energy to let neurosurgeons know exactly that, which is a little bit different than a lot of people. Like, I will literally track them down and say, this is what it looks like, because I want them to, I don't want them to just assume something. And so now some of them are really funny because I always, before I work with a neurosurgeon, I insist that I meet with them and tell them the limitations of all of my techniques.
Right.
And one of them used to go, I know, don't cut out the dotted line. Because for him, I had to tell him, look, you cannot cut on the dotted line. This is not the way we deal with the surgery.
Funny.
So anyway, but do you see why I spend so much time like sweating this out, right?
It's tough.
So you have to know your underlying data. And so that's my key. And so that's just a picture of, so here's this neurosurgeon who trusts me. And, they don't, they also understand the weaknesses and strengths, but they think that I did a good enough job, and so they're using that data. So that's why it's
there's an ease that comes across them when they can trust that type of data too. Like when they know it's accurate.
Well, and we work really hard, and and they know the limitations, and it's all about understanding what you can and cannot do with these data.
Right.
And it takes a while, and everybody's a little bit different, and so I really spend a huge amount of time with my neurosurgeons that I work with. So this is just fun because it's a research area. So remember how I said that functional MRI is not the only kind of functional data? Well, this is perfusion. So we also use perfusion to understand, because the neurosurgeons use that to make decisions about how to take out more tissue as well. So we combine all of this stuff. So they get the cortical spinal tracts, which are near this T2 signal on this person. They know where the motor strip is compared to that. They know that language is on the other side, so they kind of don't have to worry too much about that.
Right.
And then there's the hand motor knob. So see how specific that is? Boom.
Yeah.
Wouldn't you rather see that than that big huge blob?
Yeah.
So this is the bread and butter of what I do. And here's a couple, just because you guys aren't kicking me out yet. I'll tell you a couple.
I love it.
So I give a lot of lectures, and people and neurosurgeons and I go back and forth about this. And it goes back to your question of what we do, what I do map and what I don't.
Mm-hmm.
In research, there's a huge amount of interest in things like, I'm going to show you this one. Whoops. This one. Okay. There's a huge amount of interest in bilingualism, right? Everybody wants to think that the brain is just like so much better when you're bilingual, right?
Right. Has to be.
Well, it has its strengths and weaknesses, right? Because it kind of just depends. But here I am to tell you, for basic functions, you can if you're truly bilingual, mapping basic functions like I told you about, like comprehension, map the same. So this is, the blue is one language, the red is the other. I think blue is.
Oh.
Yeah. So sure. So the idea about bilingualism is it kind of depends on when you acquired your second language. It also depends. So are you translating a lot? Because you'll light up a whole bunch of part of the brain if you're still translating, because that's not really language.
Right.
But I think of language as being the symbolic representation of information. Like when I'm talking, you guys are understanding a concept, and you're not translating, right?
Right.
So I often ask people this kind of funny thing, which sounds really Freudian, but it's not supposed to be. I ask them, what language do they dream in? Because you can't control. And I started doing it because I had some bilingual people in my lab, and one of them said, it's kind of funny when I'm talking to my friends in my dreams, I'm speaking English, but when I'm talking to my grandma, I'm speaking Spanish, because we always speak Spanish.
Right.
So to me, that's a really bilingual person, because they're not translating at all. They're just doing it, because it's the symbolism of how they communicate with others, right?
Right.
So in this picture, so this is what I was trying to say, is that this is comprehension. You can see how close they had a surgery before, but then they're going to get this part taken out maybe because this signal's different. And this is comprehension of Spanish and English.
Wow.
So do you think they overlap a lot? I think they overlap a lot. And the same thing up here. This is expression. So they're saying things under their breath, in Spanish and English. And there's red overlapping with blue. Okay, so that's something, it comes up all the time for me. And so it kind of depends on how you want it. My data is really repeatable. So this is the same person 7 months apart. So that's pretty repeatable, because it has to be repeatable. Like,
right.
If you're mapping something that's just unreliable, then it's not going to work. And then this also shows repeatability. Now, this person was a little bit but this is, in my opinion, not bilateral. They really are left because there's all this activity on their left side.
Right.
But you can see that they maintained all of that. These are just different tasks and different colors.
So if they did kind of, let's say they nicked a piece of that left side, would that right side still help?
All right, so that's plasticity. So plasticity is a really also another kind of overused term sometimes.
Right. Yeah.
So it is true that people are slightly plastic, but there's probably an age related. So if you're a 50-year-old and you have a brain tumor and it's in where Broca's area is, you aren't going to be able to speak. Like your other side of your brain.
Back, huh?
But I did have an 18-year-old. I have a slide somewhere where I scanned her, and she had left hemisphere language dominance, probably a little bit of right, and she was young. And she had a tumor right in front of it, and they took out the tumor, and she went through speech rehab a little bit, and she didn't really have like a major deficit, but she had a little bit, and so then she had tumor regrowth, so she had to come back, and language was on the other side. So
no, interesting.
I think she had it both sides,
right,
and then
like
once you had the lesion,
the
language kind of.
over.
But the thing is, once you're kind of, I wouldn't. Patients really want to believe in that. Speech and language people want to believe in that, but I'm here to tell you, like, it's not as big as you think it is.
Was that person left-handed by chance? Because you said
no, they were right. Yeah. But this is I threw in this little picture because this is a quadrantenopsia. This is a vision task, and this person can't really see out of this side, and I can pick that up. So I used to give a vision task it was my control task. But now I know my data really well, and I don't really need a control task. But I give a control task, a vision task, and sometimes the patient would be fine, and no one's picked up anything, and I'm like, "Hey, look at my nose. Can you see up here?" And they're like, "No," and that task picks it up. But a neurosurgeon's not going to really bother with that because, like I said, the person didn't even know that they had a quadrantenopsia.
All right.
So they couldn't see up here, but it wasn't interfering with their life.
Right.
So vision is extremely hardwired. It's not going to be moving anytime soon. It
seems more displaced too.
Vision.
I mean, you said it's very localized, but it seems
it's in the back of the brain. Oh, it does cover your vision is so important to you that it covers a lot of brain territory in the back of your brain. And little research here is that it's relatively spared in a lot of conditions, right? So Alzheimer's disease, it takes a long time for that part of the brain to show atrophy. A lot of disorders, the actual visual cortex is maintained for a long time. I mean, people with MS have vision problems because their white matter is affected.
Right.
So that was a huge amount of information. This is just me. Remember how I told you, like, how mapping the brain is complex?
Mm-hmm.
Oh, yeah.
So finger tapping, these are 3 different parts of the brain that you need just to tap your finger. But think of, those are all parts of the brain that can contribute to memory. Oh. So it's just a ton of things. So I'm in the process of developing a new memory paradigm that I'm hoping will work, but we'll see. So there are research papers where they do memory tests. And I just read one. The person does 2 13-minute tasks.
13 minutes?
And then isolates only the area that they're interested in to get enough signal.
You couldn't be like, what'd you think about what you had for dinner last night?
I tried that. It doesn't work.
Or think about your
No,
prom
it lights
night.
up other parts of the brain, but it doesn't map that.
Okay.
Listen, this is the holy grail.
Right.
We have tried so hard. I can get really great activation of the hippocampus in group studies for research, but not for individuals.
Right.
So cross your fingers.
What about things that are closely tied to like emotions? Like, because I know like 9/11 and things like that.
Oh,
like how people remember where they were.
No, then you light up emotion.
Oh,
so there's this part of the brain. Actually, I did do this task. I actually piloted it out not so long ago where I did, there's this part of the brain called the Posterior Cingulate that is affected in memory functioning, but it's not the hippocampus. It's a little bit different. It doesn't work. It doesn't cause such a major memory problem as losing your hippocampus. Do you really want to know about memory for a couple minutes?
Oh, yeah.
So memory requires encoding, consolidation, and then retrieval. So what we're kind of talking about is retrieval.
Right.
The hippocampus is critical for consolidation. So in Alzheimer's disease, when you have hippocampal damage, you have something called rapid forgetting. So we'll give a memory test to people, and they'll remember some bits. They'll remember some things.
Right.
And then they have rapid forgetting. So like after 15, 20 minutes, they remember. Sometimes they don't even remember getting the list. Sometimes they don't remember anything about it. Sometimes they just can't remember the stuff. So that's when your classic grandmother who asks you the same question over and over again.
Right. Tell you the
At
same
the
story.
time you say it, she understands what you're saying. She's encoding it, but it's not being stored. So she just loses it, She just can't remember it over time. That's the hippocampus, and that's critical for that. So these other parts of the brain that are more easily mapped are like the posterior cingulate, which is kind of like, let's see, how relevant is this to me? It's kind of your memory relevance system. So anything that's emotionally charged is really relevant, but it really lights up the posterior cingulate. I mean, I tried that, and I get so much activity in the posterior cingulate so quickly. It's great. But the hippocampus lags way behind.
Right. Well, and two, I know that as soon as you have a concussion, they're like, who's the president, right? Or who's that? Is that still the posterior cingulate? That's kind of helping you regulate?
That's confusion. They ask you those questions for orientation purposes. And if you get your bell rung, you're just so out of it, you can't answer anything. A fever is going to do the same thing. There's not one part of the brain that's doing that. It's kind of like...
You're shaking up, right?
It's just too, yeah. So patients who are that impaired, you notice I can't map them.
Right.
Because they just can't follow things well enough.
Right.
Yeah.
Nice.
So... But yeah, so I'm working on memories. I have this new idea that I'm not even going to talk about because it's so novel that I don't know.
Plenty of wood to knock on.
I'm really excited. But if I do that, that will change things a lot because we won't, But that's been the holy grail. I've been doing this for 20 years.
Nice.
And I don't think anybody's found anything. I mean, we can't do 26 minutes of scanning on patients.
Right. Yeah.
That's the other thing. If I can talk even longer, but clinical versus research. So a 13-minute scan for a undergrad or for people who are volunteering is nothing. They know they're going to do that.
All right.
But my tasks, so I have to have much. So let me see. How do I want to say this? So research would look at my tasks and feel like these are very boring and not very interesting because they're very basic tasks. And so they're not telling us anything larger about brain functioning, right? However, their tasks aren't going to be useful at all for clinical because they're too long, they're too esoteric, they're not specific enough to functions that are relevant for neurosurgery. So my tasks, and then some of the canned tasks are even longer and more esoteric because they're aimed. They don't necessarily have a clinician doing them. They might have a technologist.
Right.
So they have to collect data on how well people are doing. But as you guys know, I'm there to make sure that the data look right immediately, and I can tell when the patients aren't doing it.
Right.
And so I can actually go back.
Right.
Somebody who was with me. Somebody was sleeping, had fallen asleep. And I was watching, and by the combination of me looking at the data and sort of movement and everything, I went back, and patients just don't want to admit that they were sleeping because they're kind of embarrassed.
Right.
And even if I tell them no, I just need to know because I'm trying to map your brain action.
Right.
And so I said to the person, so did you fall asleep during that? And they said, yeah, how did I know? How did you know? And I said, I'm literally... reading your mind. So I can get away with things that even technicians can't get away because they're not going to be looking at the data as we go along. They're going to wait till the end, and then they got to look at, did the person press a button or not? So I don't need to do that. But then the other thing is I need to make my task as fast as possible. So my vision task is 2 minutes long. My language tasks are 3 to 3.5 minutes long. And one day I scanned a person, and then the next day I did a WADA test on them. So I was, because I do all those kinds of mapping. Mm-hmm. And so and this is fairly recently, and I was talking to the person like, oh, hey, how'd that functional go for you? You did great. And he's like, that test you gave me was so long, and it was 3 minutes long, right. And still they don't want to do it, and still they're complaining. So, right. So like the transition of trying to make the translation of research tasks right. to clinical tasks is a really daunting thing that researchers, they're not really aware of what I have to do to make something work in a patient.
Right. It's almost a different ball game, even though it's the same rules.
It's different because I'm evaluating my data differently. Right. I'm not even looking for false positives nearly as much as I'm looking for false negatives. Right. The way I look for false positives is redundant mapping versus just using a thresholding method that they use, statistical method. So like it's really different. And I jump between those two all the time because I'm a researcher too. Wow. So nice. So that's what I do.
Nice.
Well, do you have a question?
Yeah, I've got a few.
Oh, you
actually,
do?
kind of along those lines. I imagine you get interesting questions from your friends and family. Like, can you think of any right now?
Oh. Well, I get the questions of like, what exactly do you do? Because it's very esoteric, know. Right. There's not that many people who do what I do out there. Right. I mean, it's really coming on board, but it's hard to find people who do what I do. Right. A lot of centers will use a technician-based, because they work pretty well. They just don't,
It's because they probably have to because you're so rare.
Yeah, right. So I want to build a training program to make more people like me,
For sure. That's amazing.
But what do they ask me? Well, most people ask me about mapping things that you just can't map, that I don't map, right? So usually it's some sort of mapping issue of like, can you map that? Or they'll say something like, well, we know that works, and I'll just roll my eyes because it's not true. And it's just, once you start doing this for a living and you've seen patients and you've seen their brain and everything, you realize that a lot of things that are in pop psychology, that's the thing. They always ask me pop psychology. Well, I'm a right brain person. And I'm like, I'm pretty sure you're using both sides of your brain. So.
I love that.
I guess along those same lines, we've been asked some questions by some of our coworkers to ask you, and some of them were like,
oh, okay.
Yes.
Like, for like, as far as, can you map that? Well, can you do lie detection?
Oh, research says you can do lie detection. You have to use machine learning. I personally choose not to do some research and don't do things. Like, so I personally am a clinical neuropsychologist clinician. So I'm most interested in translational research that can help patient populations or other populations. So I have one of the largest, I started it and my old postdoc took it over. So I have one of the largest studies of older adults with autism to try to understand better what their needs are as they get older.
Oh, that's interesting.
So lie detection, people do study it. Actually, I saw on your list of things, like, what would you be if you weren't a neuropsychologist?
Yeah.
I probably would be a behavioral neurologist or a behavioral
therapist,
economist.
Oh,
because something that's super interesting. No, it goes back to your lie detection.
Yeah.
Because something that's really fascinating to me is what people will spend money on and what they won't. Because we're all super quirky. Can you guys think of anything
so
like?
Right.
Like you'll have no problem dropping $70,000 on a car, but like
I think we have a different budget than you.
You won't buy a brush or something.
Right,
No, these are people.
Right.
For me, I noticed that I won't, like, I'll think, because things that I've bought for years and years and years, in my mind they don't go up in price. So I was just noticing, like, a bottle of ketchup to me is like $1, and if it's more than $1, I'm like, this is too expensive. I don't want to buy it. But a bottle of shampoo, I'll spend $25 on, and I don't even bat an eye, right? Like, because I like shampoo, and I can notice the difference. But ketchup, no, it's not worth anything. So I think behavioral economy is really interesting, and lie detection. Those people love those kinds of tasks, like lie detection, because what people use it for is marketing purposes, and that's the whole thing where they try to figure out like your interests, and so lie detect. So the way you do studies for that is you do extremely long tasks that have all these different items, and then you pool the items together and you try to figure out if you can if somebody is what parts of the brain. What it is it's this P300 signal. Like, you can do it with EEG too. There's certain parts of the brain that are associated with attention that'll just be like, bah! If you tell a lie, right? Like if you
think more about that lie than you would if you had to tell the truth, type of thing.
Yeah. Do you know a little factoid? I know I have lots of them, but police officers will make people tell their story backwards. And the reason is because if they're lying, they won't be able to do it because they don't have an image of what really happened. They have a story that they learned, and they learned it forward, not backward. So they
use that on my kids.
Yeah, they pick up.
So that's how you pass a lie detector test.
Right. So like, it's really hard to tell, like, it's like your brain doesn't really process a lie as easily as it processes the truth.
Right.
And it activates like certain attentional systems that you're needing for control, like when you tell a lie. But it takes a huge amount of data to do that kind of machine processing for the data. So I don't do any of that. And also, I'm a clinician who's really interested in what I'm interested in, which is pre-surgical mapping. So I just don't get into all that, because then you get into forensics and things like that, which I'm not interested in.
Right.
Well, we're probably going to cover a couple more things. Well, another question somebody asked me as far as can you map it is, I imagine you can see emotion, right?
Yes.
And the different parts that take up that, but along those same lines, can you determine whether somebody lacks that, therefore like defining them as like a psychopath?
Okay, so that's the diagnostic thing that people do. So there is one researcher who looks at antisocial personality disorders, and he works a lot in that. And like I said, so if you think about what we're doing, lack of signal doesn't tell you a lot, right? So I'm going to circle this back and talk about my data a little bit. The reason why I don't have a really great memory task is because it doesn't always light up in both hemispheres in all people. And think about that. So if you're missing it, and if somebody says, I use my left more than my right, so I'm not going to light up my right, just because that's their individual difference on this particular task, I can't use that, right? Because I can't. Lack of signal is because the person didn't do it, they didn't pay attention. Like, it doesn't tell you anything. It's not clear. Like, I can't, like the neurosurgeon, like I need to know that the person did the task. So sometimes I don't send my data to the doctor, because I'll say this person failed, and I don't know why they failed, but they didn't light up their brain well enough to pass muster for me. So functional MRI, you have to see signal, right? For you to make any kind of decisions about what it is. So lack of signal in functional MRI is very nebulous area, right? So I actually did map emotion. I have a task that maps emotion. It's really pretty cool. And I published some papers on it because at one time people wanted to do, they still kind of do it in a research mode, but we were kind of, as a field, interested in transitioning into functional neurosurgery on patients with depression by putting a deep brain stimulator in this one part of the brain. So I was asked by that same neurosurgeon who only uses 3 words, can you map
Right.
area 25, which is the area that people wanted to target. And so I created a task that in individuals, I could map it.
Wow.
And it moved around a little bit, probably enough to make the deep brain stimulators not that successful because they targeted one place and they weren't quite hitting exactly the same place. They were using anatomy and not functional.
Right.
So to make a long story longer, you can map emotion, but depending on your battery of tests, you would never know that a lack of signal is really due to a lack of emotion.
Okay. And this one's kind of a fun one for me. It's actually something I've thought about for a while. So with functional MRI, in my mind, in theory, like you said earlier, actually you could read people's minds, but I'm thinking how you can actually use that. One scenario that I came up with is you'd almost have to know in advance, but what if you map somebody's brain completely? And then months later, they're now in a coma, and they're in this coma for months. While they're in this coma, could you do an MRI of them, see what parts of their brains are activating, and in theory, tell what they're thinking about in their coma?
Oh, well,
you could see their emotions. You could see if they're happy or they're sad.
That's really interesting. Well, theoretically, yes.
Yeah.
Like that theoretically, but that is a huge theory, right? Because that would mean that everybody would get their brain map for everything, right? And that we get to the point where we can actually map everything in the brain. Probably closer to that, what we would do is we would what you're kind of saying is sort of that big picture, like, will we at some point get all of everybody's genetic sequences will all be mapped? You know what I mean?
Right.
Like, will we map people out completely? I think the standard of healthcare is not there that we're going to go that length of time. Yeah.
Right.
But theoretically, functional MRI, I think that functional MRI is a very useful technique. I'm hoping that there's going to be something even better out there to map the brain.
Right.
Because, as you can see, there's a bunch of different ways to map the brain. But theoretically, in some sense, we could map the brain, and then we could predict, based on lack of function later on, what was missing. I mean, that's what Google's doing all the time, right? That's machine learning. So machine learning is changing a lot of ways of brain mapping, et cetera, because basically people get these huge data sets, and then based on those data sets, they try to predict what's going on in a new data set, a test data set. And so you theoretically could do that. So you could use the pre-data set to predict what's missing from the post-data set. And you wouldn't really have to go through my task-based stuff to do that. There's this other kind of functional MRI that we do all the time is called resting state.
I was going to ask about that. Yeah.
Yeah. So resting state is theoretically you're in some sort of state where you're not doing anything like I asked them to do. And then we decide, we know certain networks in the brain, neural networks in the brain, and then we can analyze the data and figure out where those neural networks are. And I do that kind of research. I published on resting, using that approach to look at neural networks. And I hope actually my not too distant future that I'm going to use a neural network approach on what I'm doing right now to just increase the robustness of my data.
Oh, nice.
But basically, theoretically, you could definitely do that. And that people are mapping people's brains while they're in comas. You can look up that literature, and they'll give them, what they do is, it's the flip side of what you're talking about, is they'll give them something to think about. I think they did, I forget where the group is. It's somewhere out east, either in Canada, like MNI, or somewhere out east, where they would talk about tennis to the person, either do something related, read something about tennis, tell them something about tennis, and then they can see activation in motor parts of the brain.
So the people are actually very aware of their surroundings.
Well, it's very controversial right now, but people are trying both that and with CT scans, because one of the neurosurgeons I worked with worked on CT scans to try to better understand what true brain dead what truly
consciousness is.
I have a theory that people are more
dead.
so than we give them credit for. Like if I have a patient that comes down and they're non-responsive, I still talk to them. I say, hey, I'm going to move this, I'm going to do that.
Yeah, that's really
that's a good,
well. I think that's nice. I actually, I think kindness to patients who are going through this is really hard to maintain when you see patients day in and day out.
Mm-hmm.
But it's always a nice thing to remember that whoever's coming in, this is a terrifying thing for them.
Right.
I mean, maybe if they've got like an ankle injury, it's not. But especially the brain tumor patients and the brain patients, like they're going to go through surgery. Like that is like, we can't relate, know? And I actually tell them like, I can't relate. Sometimes I talk to them just so that they understand that, I'm taking this seriously. I understand what they're going through, and I'm going to try to get them through it the best. So I think that's wonderful that you talk to people who, what's worse is when people start making, there's been a lot of controversy of people thinking that people are under anesthesia and talking about them in front of them, and the person wakes up and said, I heard everything you said.
Yeah.
So kindness to patients is always a good,
Right.
And just, you made me think of a funny story. I remember I read in the newspaper, I don't know, actually who reads the newspaper anymore? I read online, some lady actually had like a tape recorder or something recorded.
Oh, yeah.
While she was under anesthesia.
No, you can get in,
Wow.
And then the nurses were talking about her. And
one would hope that we don't have to be, worried about lawsuits and stuff, and that we just be kind to people. But there's burnout, after a while, if you're doing the same thing all the time, you can burn out. But it's always good to remember, like human beings are,
Well, and that kind of brings me to a question that I had. I guess even when you're under anesthesia, sometimes you can have some sense of consciousness, right? What is highlighting in your brain?
I have a very nerdy husband who's just as nerdy as me, and I shouldn't really admit this, but yesterday we spent a good chunk of the time talking about memory functioning because, of course, I'm really trying to build this memory task. So, so we were talking about this. We talked about this. So memory has a time component, and so because he had just seen this lecture about there's a famous Nobel Prize person who showed place cells in the brain and grid cells in the brain in the hippocampus. We always go back to the hippocampus, right? So like it was remembering, like you were learning things based on where things were spatially.
Right.
Well, I that's very important, literature, but of course in humans it's all conversations, verbal, language, so that's where I live. So it's very hard for me to kind of wrap my brain around just looking at spatial. And these people work on rats who have no language, right? So all they have is navigation, right? So we're going back and forth. But we brought up the new thing that people are finding is the component of time.
Oh.
And so it's true. So think about if you undergo anesthesia, you wake up and you have, it could be
like a blink, or
you're just like, they just put me to sleep, right? Because there's subcortical and hippocampal mechanisms that are just completely turned off. And so you're not tracking time, because when you wake up from a nap, right, that time traveled because your brain is still active. Your hippocampus is still active. Your hippocampus is a very, very active part of the brain, which makes it hard to do functional MRI, right?
Right.
And because you're looking at these tiny little changes in brain activity from condition A to condition B, right?
Mm-hmm.
So the hippocampus is so active all the time, it's hard to get these slight changes in brain functioning. Your hippocampus has been working all the time. It works at night to consolidate your memories. That's, part of dreaming and all of that.
Mm-hmm.
So to get back to your question, the hippocampus is tracking time. So it's probably, along with other parts of the brain, it's probably put it to sleep enough that but we don't know about comas.
Right.
I think drug-induced comas are going to be different.
Right.
And the type of medication that you're on, I think, varies too, because people on Versed can correspond with you and follow directions, even though they will not remember
a thing, right? Yeah.
Some do,
right?
Which, but most don't.
So interesting.
So exactly how you're drugging out your brain, I think, varies from person to person, but also it's not hitting all parts of the brain the same way.
Right.
I'm not an expert on anesthesia. So
No,
no, that was a perfect answer. That was good.
Yeah, this has been a lot of fun. Thank you for joining us. We appreciate it. One question we do like to ask all of our guests. You've probably seen in the packet. We want to prepare you a little bit, but what would you say has been the most satisfying or memorable moment in your healthcare career?
When you figure out this memory task thing?
Well, no, I think it's this patient I had. It's the patient. It's always about the patients, right? But I did brain. I had this younger girl. She was like in high school and just silent. And I mapped her brain with functional MRI, and then I did awake mapping with her. And, awake mapping is very scary, right? You wake up and you have to stay still, and somebody's doing brain surgery on you. And so I'm there, and I feel like it's back to what we get, you said about being nice to the patient. There I'm mapping the brain, but my goal is to be just as nice to the patient as possible and get them through this really what must be very difficult situation. So anyway, a day or two later, I get this call from, they're trying to track me down, and the mother wants to talk to me, and I'm like a little panicky, right? Because like usually I don't have to round or anything with these patients. I'm a consultant to the neurosurgeon. So I just happened to be going past the neurosurgery offices, and I popped into the neurosurgeon. I'm like, did so-and-so have any problems? Like, and he's like, no, I don't know any problems. So I went up to the room, and the mother's like, oh, thank you, Dr. Baxter, for coming. Because all she's been able to say since she came out of surgery is, Baxter, I want Baxter. And I'm like, really? And so I went up, and I was just really, and so I talked to him for a little while and everything. I think it was like the day after surgery, and I talked to him for a little while and just tried to say some, clinical things of like, what it'll be like to get better and how's she feeling and stuff. And then I walk away, and she was quiet the whole time. So she's your typical adolescence. Like it was so shocking to know that I had made such an impression on her, because she didn't really talk to me all that much, just like a teenager doesn't.
Right.
But clearly she had, I had been, I think, comforting to her. Yeah. And then when they came back for like a visit later just to check up, they called me back over there, and she had a present. And so on my desk, I have this little, framed thing that says it says something like, you are the best, most perfect, most awesome, wonderful person ever. And I keep that up there. So I remember it's all about the patients. It's all about the patients. It's all about the patients. And you don't even know you're doing something positive, and you are. So I would have to say that's probably the thing that keeps me going and reminds me like what my day job really is. That's to help patients.
I think that's a great transition out. I think you're doing a lot of positive for the patients. So thank you for that.
Well, thanks.
And thank you for joining us. Reggie, do you have anything to say?
Actually, we had a similar conversation where we were, thinking of a guest, and I was like, I want Baxter. I want Baxter.
It is true.
It's been fun to be here.
No, we're so glad.
So you're definitely wanted.
Yeah.
And you're definitely appreciated. So thank you.
Yes,
and thank you for watching. We're Zone 3 Podcast. We have a website, zone3podcast.com. We have a store there. We ask you to do all the things that YouTubers ask.
Yes.
Hit subscribe, hit like.
Thank you for all our subscribers out there already.
Yeah, we're trying to get to 1,000. We're pretty close.
We appreciate the love. Thank you, guys.
Thank you, you guys. Zone 3 Podcast. Thank you, Dr. Baxter. We're out.